Just a moment to let more attendees join. We're almost to start.
Almost 100.
Yeah. All right. Thank you all for your patience. I think, yeah, we can get started. Good evening, everyone. Welcome to the Kappa Online Education Program. I'm Gao Li, second year pathology resident at Hershey Medical Center. It's my pleasure to welcome you to the third lecture in our gastrointestinal pathology series. Thank you all for joining us. And tonight, we're honored to have Dr. Lihui QIn with us. And Dr. QIn is Associate Professor of Pathology at Cornell University, New York Presbyterian Hospital. And Dr. QIn received her medical degree from Beijing Medical University, followed by a PhD in immunology from the Medical University of South Carolina. And she completed her postdoctoral training at the University of Michigan and later completed her pathology residency and gastrointestinal pathology fellowship at Mount Sinai School of Medicine in New York. And over her distinguished career, Dr. QIn has served at several prestigious institutions, including Yale University, Mount Sinai, Hofstra Northwell, and Weill Cornell. She is a board certified anatomic pathology with over 22 years of experience, specializing in gastrointestinal and liver pathology, and has made significant research contributions in neoplastic and immune-mediated gastrointestinal and liver diseases. Tonight, Dr. QIn will be sharing her expertise in a lecture titled Inflammatory Bowel Disease and Its Mimics. Dr. QIn, we're so delighted to have you here tonight. Yeah, you may take it from here.
Yeah. Thank you for the invitation and nice introduction. So today I'm going to talk about inflammatory bowel disease and its mimics. Oh, sorry. Okay. So before we talk about IBD, I wish everybody know this is Dr. Krohn, and he is a gastroenterologist at Mount Sinai, long time ago. So in 1932, Dr. Krohn and Dr. Oppenheimer and Dr. Ginsburg published this important paper called regional enteritis. And later on, this entity was named after Dr. Krohn. And please pay attention to Dr. Klampra. He is the pathologist who actually described all the cases they described in this paper, but his name is not even acknowledged. So just for now, we still be careful. Some clinicians still do this kind of things to us, and we need to protect our name and authorships. So inflammatory bowel disease, and basically it's a chronic relapsing inflammatory disorder that involving colon and small bowel. Basically, there are two types, ulcerative colitis and Crohn's disease. And their mechanism is very complex, involving genetic, environmental, and immune dysregulations. So on biopsy, chronic colitis had very characteristic features. So here we can see a normal colon, and we're talking about the typical test tube arrangement for the crypt. They are same size and same caliber, run in parallel and sitting on the muscularis mucosae. You do see a little bit inflammatory cells, but not too much. And then it's more towards the surface, and then gradually taper down towards the base. On the other hand, chronic active colitis, you can see there's a lot of inflammatory infiltrates. They are full thickness and basal lymphoplasmacytosis. And then you can see crypt architectural changes, and you can see neutrophils in the epithelium and forming abscess. And sometimes you may see pennicell metaplasia, pseudopyloric metaplasia, or granulomas. And that's the basic histological features. And in chronic inactive colitis, you may not see a lot of inflammatory cells in the lamina propria. You're not going to see neutrophils in the epithelium, but you still see the architectural changes, and you see pennicells in the left colon. And some chronic inactive colitis shows this crypt atrophy. You see there's no crypt in large expand of the area. And, the chronic colitis is a kinetic process. So the chronic active after treatment may become chronic inactive. And then after months and months remodeling, they may be completely normalized. So you need to know that the changes is not always the same. So in Crohn's disease, you may see some unique features, for example, fissure, and this is a very deep ulcer. Sometimes we describe knife cut, like a knife cut through, and you can see the inflammatory cells goes all the way deep into the tissue. And Crohn's disease, you often see patchiness of inflammation, which involving the left side of the biopsy, but the right side looks completely normal. And you may see pseudopyloric metaplasia. You see this group of crypt. The nuclei become much smaller than the enteric mucosa, and the cytoplasm is more pale. They don't have goblet cells. They look like the pyloric gland of the stomach. So once you see that in terminal ileum and sometimes colon, there's a chronic injury there. It may be seen more often in Crohn's disease, but itself is not specific. And you may see ulcer on the top. And sometimes you may see collection of histiocytes, so we call this granuloma. Once we see that, we think, oh, this is probably a Crohn's disease. But you need to make sure, first, granuloma may be due to Crohn's disease and may be due to other things like foreign body, like infectious, like sarcoid, and you have to make sure it's Crohn's granuloma. And also you have to know the Crohn's granuloma only see in less than 50% resection specimen. So on biopsy, you may see less than 5%. So seeing granuloma is a more diagnostic for Crohn's disease, but if you don't see granuloma, it doesn't exclude the diagnosis of Crohn's disease. So in summary, for chronic colitis, we see chronicity, including dense, full thickness, and basal lymphoplasmacytosis, crypt architectural distortion or atrophy, without pennicell metaplasia, pseudopyloric metaplasia, and granulomas. So when we talk about activity, we're talking about neutrophils in the epithelium, without ulcer or erosion, with or without fissures. Okay. So once we determine the biopsy is either chronic or chronic active, next question is this IBD or not, right? And if that's IBD, is that Crohn's or that's UC? And if that's non-IBD, what that is, right? So today I'm going to discuss all of these questions. So in medical school, at textbook, it seems like there are two diseases can categorize into idiopathic inflammatory bowel disease. One is Crohn's disease, the other is ulcerative colitis. So Crohn's disease can involving both colon and small bowel, and you can see skip lesion, and you can see strictures and fistula. So if you take a cross section and you can see transmural inflammation, you can see fissure or deep ulcer, you can see muscular hyperplasia and the fat cripping. Right? Ulcerative colitis, on the other hand, only involving the colon and mostly distal colon, and they are continuous and no skip. And if you take a cross section, there's no muscular thickening, no creeping fat. You do see ulcer, but usually they're superficial, just in the mucosa, and then you may see pseudopolyps. And about 80 to 85% of IBD will follow this path, and we call this disease read books. Okay, so we can easily identify a a linear ulcer. We see wall thickening, and there's a hole. It's probably a fistula, and then you can see there's a creeping fat outside. And you can see that's continuous erythematous and ulceration involving distal and mid colon. And then the right colon may be still normal. And here you can see there's a fistular connect to segment of bowel. That's called the fistular tract. So on textbook, it seems like there are two diseases. One is Crohn and the UC, and we did talk about all the features. But in real world, life is not that easy. So about the 15 to 20% of IBD do not really follow these two categories. They have overlap features, which is difficult for us. So what's the atypical feature of IBD? So sometimes Crohn's disease may look like UC. So we're talking about superficial Crohn's colitis. And then more often UC may look like Crohn's, and they may see transmural inflammation, they see skip lesions, they see ilio segment were involved, and rectal sparing and upper GI involvement. So first, superficial Crohn's disease. So look at this specimen. We can't really see too much of the inflammation or look like a Crohn's disease with strictures, creeping fat, or anything. Even on a cross section, we can see the inflammation is mostly in the mucosa. And some mucosa, we do see some lymphoid aggregate, but it's not really inflamed. And muscular propria and serosa look completely normal. But if you look careful, we usually take a lot of sections for IBD, and we need to carefully examine every single cases and pay attention to the granulomas. And we do see this kind of aggregate of histiocyte. They have very, like oval or round nuclei, a lot of cytoplasm. They're pale or pink, right? And compared to the lymphocyte, they have a lot of cytoplasm, and they forming a group. So that is a granuloma. So this case, and we call it superficial Crohn's colitis, and that's only involving the colon, and they look very superficially involved. So why do we call this Crohn's colitis instead of UC with some weird granuloma? And 25 years ago, Dr. Harpas at Mount Sinai did this study. He followed 10 patients with this kind of a superficial colitis with granuloma. And they see what happened with the pouch, right? So what they see is many of the pouch failed due to refractory pouchitis, sometimes perianal fistula, and then finally the pouch has to be removed. So biologically, this superficial Crohn's disease behave like a Crohn's, not a UC. That's why this is categorized as a Crohn's colitis. So the feature we have already discussed, macroscopic grossly, it looked like a UC, right? Don't have any cobblestoning, fistular stricture, don't have skip lesion. Microscopically, it also looked like a UC. And some area may have some deeper involvement, but it's very little. The only thing distinct this with UC is you see granulomas. So you can see based on the gross and microscopic examination, they actually cannot really tell this is UC or this is Crohn, but biologically they follow the Crohn's disease. So that's the disease, superficial Crohn's colitis. So Crohn's can mimic or look like UC, and UC sometimes can also look like a Crohn's disease, particularly in the setting of fulminant colitis or the patient with inflammatory pseudopolyposis. So for example, this patient had UC, and you can see there's a lot of, like we described as a carpet-like pseudopolyposis. So within this polyp, and then you can see there's inflammation goes all the way deep into the muscularis propria, look like a fissure, right? Usually we say fissure is only seen in Crohn's disease, but in fulminant colitis or inflammatory pseudopolyposis, you do see fissuring ulcer. And we always say Crohn's disease has skip lesion and UC is always continuous. But in this setting, you can see here on the left colon, and there's a diffuse erythematous, right? And then ulceration. And then you have a normal right colon. Then on the cecum, you can see an ulcer again. So this is so-called ulcerative colitis with isolated cecal patch. So although you do see skip lesion, but this patient is still ulcerative colitis, and biologically it follows UC. And in recurrent disease, you do see this patchiness of inflammation in ulcerative colitis. So patchiness is not only seen in Crohn's, but also seen in UC. And here again, if you biopsy a transitional zone, then you can see there's a normal, and then another area shows chronic active colitis, and this is still UC, not Crohn's. And if the patient was treated with immunosuppressant, in this case cyclosporin, and you can see there's a skip lesion, skip ulcers, and then in between there's a relatively normal or even normal. So skip lesion in post-treatment patient. And we always say UC is a colitis, do not involving the ileum. But if you have a very severe UC that involving cecum, then the ileocecal valve might be involved and then become very inflamed and dysfunctioned. So in this case, the bowel contents from cecum may go back to the ileum and cause ileitis. In this setting, it's called backwash ileitis. So although you see ileum become inflamed, and the patient is still UC. So how can you tell this ileitis is due to Crohn's or this is due to UC? And usually in backwash ileitis, you see most distal terminal ileum less than 5 centimeters or inflamed. And some people may accept like 10 centimeters. Some people think, oh, 2-3 centimeters, but average, if it's 5 centimeters, it still can go with the backwash ileitis. And the second, usually for ileitis, you see the mucosal inflammation, but usually not very severe, and no granulomas, fissure, or transmural inflammation involved. Okay. And then usually you have to see cecum become involved. Otherwise, ileocecal valve won't be affected, right? You can't explain why there's a backwash ileitis. So when you see this, it's probably backwash. But for Crohn's, you see more severe inflammation. And usually the ileitis is more severe than colitis in the cecum. And usually you will see ulcers, stenosis, and you see granuloma, pseudopyloric metaplasia. Okay. Rectal sparing. So when you hear this term, usually the clinicians thinking, oh, this is probably Crohn's disease, because UC is usually more severe in the distal part of the colon, particularly rectum. So if you see the rectum is not so inflamed or rectum is normal, clinicians think it is Crohn's, but it's not always the case. If the patient was treated, or if the patient had in a pediatric patient with new onset UC, and you may see rectal sparing. And focally enhanced gastritis. So this terminology, not everybody will accept. So what that means is, when you do upper GI biopsy, gastric biopsy, most of the biopsy looks okay or only mildly inflamed, but you do see some area is very severely inflamed. On high power, you can see there's a dense lymphoplasmacytic infiltration, and then there is a crypt damage, but it's only focal. You may see just one or two focus in one biopsy. So some people use this term focal enhanced gastritis. And what we take on is focal enhanced gastritis in pediatric patient may indicate the patient had Crohn's disease. So for pediatricians, if you use this terminology, they are going to do like a colonoscopy to make sure the patient don't have Crohn's disease. But this finding is not so specific for adult. So what we take on is usually for pediatric, we say focal enhanced gastritis, and then we put a note to see more often seen in patients with Crohn's disease. And for adult, we will say focal chronic active gastritis. We don't make too much of noises because, for adult gastroenterologists, they don't take that too serious. And in adult, the correlation between focal enhanced gastritis and Crohn's disease is not so accurate. So upper GI involvement on textbook is always Crohn's disease, but it's not always true. Yeah. So definitely, if you do see granulomas, that most likely means Crohn's disease, right? And then lymphocytic esophagitis is most likely seen in Crohn's disease, particularly in pediatric patient. Focal enhanced gastritis, as I mentioned, for pediatric patient, it's very likely to be Crohn's disease. But for adult patient, it might not be so specific. And you do see in UC patients, particularly in adult. And then the basic line is upper GI involvement cannot be used to distinguish UC and Crohn's. And this what we learned from medical school, and which is not true, not 100% true. And for pediatric patient, we have to pay special attention, because their changes can be very subtle. And you may not see architectural distortions. And the reason is two things. One is for pediatric patient, they may see a doctor earlier because when the kids had 2 weeks of diarrhea, the parents will bring the patient to see doctor and do colonoscopy. But if an adult had 2 weeks of diarrhea, nobody cares. And you might need to have 2 months or 3 months before the adult patient come to see the doctor. So the real chronicity of architectural distortion may not be developed in pediatric patient. The second thing is for kids, their immune system may not be well developed, so their changes may not be same as adult patient. So what is the unusual pattern for pediatric patient? First, you may see patchiness in UC. Okay, so patchiness is not a diagnosis for Crohn's, particularly for pediatric patient. And then you may see rectal sparing, and you may see absence of architectural distortion. So for pediatric patients, you have to be very careful looking for the subtle changes, but do not make a definitive diagnosis of UC versus Crohn's. So here I summarize the typical features of UC, and then you can see fissures, you can see transmural inflammations in fulminant colitis or inflammatory pseudopolyposis. You may see skip lesions or patchy inflammation. You may see ileitis, rectal bleeding, and upper GI involvement. So the classic feature of UC and Crohn's still hold true for 80 or 85% of the patient. But for the other 15 to 20%, and there's a problem, right? So you can see this picture, and this on the left side is obvious Crohn's disease, right? You see transmural inflammation, you see granulomas, lymphoid aggregate just next to the muscularis milk propria. And then on the right side is clearly look like a UC, and you can see the superficial inflammation, but down deep it's all clean, right? So that's the resection specimen. So if we take a superficial biopsy, can we really tell the difference between Crohn's and UC? And do we need to? Do we need to distinguish UC versus Crohn on biopsy? And depending on where you practice. So if you practice in New York, we don't need to do that, right? So, and we sort of educate our clinician, this Crohn's and UC can be very similar on biopsy, and we can't really tell, right? So then the clinician usually will accept that. But in some institute, and even in the very prestigious institute, the clinician will prefer you give them a diagnosis of UC and Crohn's on biopsy, because they think they can treat UC and Crohn's differently, okay? So if you work in that kind of institute, you make sure first tell the clinician 15 to 20% chance you could be wrong, right? That 15 to 20% is a very high percentage. If you're wrong, then they have to accept that, right? The second thing is you need to know the clinical radiological endoscopic findings. And third, you only diagnose this patient which is untreated. For treated patient, then everything can change, right? And also you need to make diagnosis in non-pediatric patient. For pediatric patient, it's very different stories, okay? Oh, sometimes we can give a hint, on biopsy if the patient look like a Crohn's disease. For example, if we see granuloma, but of course, granuloma have different kind. We have to rule out the infectious kind of granuloma, sarcoidosis, foreign body type, crypt rupture. If we can exclude that and we see a granuloma typical of Crohn's disease, we can make a diagnosis of Crohn's disease, right? If we do not see granuloma and we see the following, we can say we favor if I have to make a choice, right? So if we see patchiness in untreated non-pediatric patient, patchiness is a favored feature, right? Or focal enhanced gastritis in pediatric patient, lymphocytic esophagitis, believe it or not, is correlated with Crohn's disease, and particularly for pediatric patient. But of course, lymphocytic esophagitis is not the specific one, because some of the skin conditions like lichen planus, right, and dysmotility and some drugs therapy can all cause lymphocytic esophagitis. You have to exclude that. Right. And then, of course, if you see pseudo-pyloric metaplasia in terminal ileum, you can exclude insect-induced injury. You can say, oh, favor Crohn's disease. And still some disease that do not read books, right? And they show some overlapping features of UC and Crohn's, and we cannot really make a definitive diagnosis. So here there's introduced a terminology called indeterminate colitis to describe this disease that do not read books, right? So you have to know when you use this terminology, clinicians also use this terminology. What that means is different, right? For clinician, they're thinking indeterminate colitis is etiology and type of colitis cannot be determined. Okay. But for pathologists, the definition is different. And we think indeterminate colitis is the patient had IBD, but we cannot really tell Crohn's or UC, and we call it indeterminate colitis. And the reason we can't really make a diagnosis of Crohn's or UC, we have already actually mentioned, and Dr. Oz had a very nice review article about indeterminate colitis in modern pathology. So basically, because the feature we have talked about, UC may look like a Crohn's, and Crohn's may look like UC, so we can't really determine this is UC or Crohn's, at least at this moment. And later on, the disease may develop, and then we can further characterize into one or the other category. So for pathologists, and we need to use this terminology in resection specimen. Usually we try not to make a distinguish between UC and Crohn's on biopsy. So we leave this terminology in resection specimen, and then that's the thing. If we can see there's a colitis, and then there's rectal sparing, but there's no other Crohn's features, right? And then we can see ileitis with atypical for backwash. We usually backwash is milder, right? But it's a little bit more than backwash, but not enough for Crohn's disease, and we can use this terminology. And if we have severe focal gastritis, and then we can have pancolitis with focal transmural inflammation or anal fissure, but we don't know the history if the patient had fulminant colitis or not, right? So then we can leave that for resection specimen for this terminology. Okay, now we talk about IBD mimics. A lot of disease can mimic IBD. For example, this patient, you can see there's basal and full thickness lymphoplasmacytosis. And look on low power, the crypt architecture looks altered or distorted. But if you look at a high power, and you do see a lot of inflammation, but the crypt shows a lot of apoptosis, right? And then we do not really see goblet cells, and we do not see Pennant cells. So this is not IBD. This is called autoimmune enterocolitis or autoimmune enterocolitis. Depending on how much inflammation you have, either enterocolitis or enterocolitis. And this kind of patient had autoantibodies against enterocyte and goblet cells. So the goblet cells are disappeared, and then you can see these apoptotic cells, that's immune-mediated injury attacking enterocyte, okay? So how do we make a diagnosis? And you need to take patient serum, which is supposed to have antibodies, and then you incubate with normal colonic mucosa or small bowel mucosa containing goblet cells. And then you use immunofluorescent labeled second antibody, you can highlight goblet cells. That's the diagnosis for this entity, autoimmune. And the second thing is segmental colitis associated with diverticulosis, SCAD. That's basically is IBD-like inflammatory changes around the diverticulosis. So if you only see a mucosal biopsy, you can't really tell this is IBD or this is a SCAD. You can see the architectural changes, some inflammation. Sometimes you can also see like a fissure, right? And then you can see granulomas. And you can't really tell, right? But some hint will allow you to think about SCAD is if you can see the segmental colitis only in the segment with diverticulum, and we know sigmoid is most likely had the diverticular disease. So if the biopsy, everything's normal except the sigmoid become chronic inactive or chronic active colitis, you should think about SCAD. Right? And then you need to look at the endoscopy report to see if there's any diverticulum in this area, or at least you need to put the SCAD into differential diagnosis, IBD versus SCAD. And for SCAD, after they resect this segment, the patient will be cured. But for IBD, it will recur. So distinguish these two diagnoses is very important for the patient. And this look very inflamed. No, I won't say the word. Yeah, you can see there's some gland, but it's really separate from the other group of gland, and they are separated by a lot of mononuclear cells. So it's this IBD, right? And if you look careful, these are lymphoid aggregate, right? They're not like a diffuse. They forming lymphoid aggregate. You have a prominent germinal center. So if you look higher power, there's mostly are lymphocyte. You don't see much plasma cells, right? And then if you see the gland, they actually get pushed by the lymphoid aggregates, but they're not very injured. So this is not IBD. And when you see this kind of pictures and you need to check this clinical history or surgical history to see if this part of colon is diverted, right? The diverted part of a colon do not have a short chain fatty acid from the stool. So the epithelium become injured and you have lymphoid aggregate. So if the patient had the surgery, then this is diverted part of colon. You see IBD-like feature, follicular lymphoid hyperplasia, and you can make a diagnosis of diversion proctocolitis, or you can just simply say diversion effect if there's no epithelial injury, right? So diversion colitis can mimic IBD, but if you know the the clinical setting and you see a lot of lymphoid aggregate in the colon, particularly rectum, think about diversion. Yeah. And here you have example, and histologically it look identical to inflammatory bowel disease. But the clinical setting is this patient don't have chronic colitis, and the patient had organ transplant. So after organ transplant, they develop this kind of colitis. It's called post-transplant inflammatory bowel disease, which opposite to the regular IBD is idiopathic inflammatory bowel disease. And this one we know is post-transplant, and most likely is due to the immunosuppressant and immunodysregulation. So this is not, what we talk about IBD, and it's a post-transplant IBD. How about this one? So here you have full thickness and basal lymphoplasmacytosis, and you have some crypt injury and some neutrophils in the crypt and with a lot of crypt damage. And when you see this, is that IBD, right? And what's the difference between IBD and this one is you can see, although there's a lot of lymphoplasmacytosis, and it doesn't really as blue as what we like to see. And also the architectural changes is not quite there, right? So this is actually not IBD, but patient with prolonged infectious colitis. And the feature is, as I mentioned, the basal lymphoplasma cell cytosis is less dense, contain less plasma cells, but more histiocyte, and it's probably some edema, so make it look not as blue as what we see in IBD, right? And crypt architectural distortion, penicillin aplasia is usually not seen. And then another thing very important is neutrophilic infiltration in infectious. You can see both in lamina propria and epithelium. But if you have IBD, most often the neutrophils is in the epithelium. And this is a very important feature to distinguish IBD versus non-IBD. And for infectious, another thing we need to know is Yersinia infection, right? So they can have granulomatous enterocolitis resemble of Crohn's disease. And particularly for Yersinia, the most often affected area is terminal ileum, which is similar to Crohn's disease. And they have granulomas, transmural inflammation, fissures, which really mimic Crohn's disease. And what important histological feature is, the first you see a lot of granuloma. Usually for Crohn's disease, we have to look for it. And if you see a lot of them, particularly if you see something like this, and there's a granuloma, but in the center, there's a lot of neutrophils. So we call it a suppurative granuloma. Or you can see the granulomas always in the follicular, lymphoid follicle, inside follicular follicles, and you have to start thinking of Yersinia, yeah. And of course, TB is always indifferential, but TB, you see necrotizing granuloma, and Crohn's, you see non-necrotizing granulomas. How about this case? And here you see architectural distortion, right? Full thickness and basal lymphoplasma cytosis really look like IBD, right? And then same thing, this case, and you can see architectural changes. You see a lot of plasma cells, some maybe erosions. And so if you only see the histology, you can't really tell this is IBD or this is non-IBD, right? But when we look at this case, right? So this is a 61-year-old and never had IBD. And the clinical feature is normal CT. And of course, the clinician may not always give us the clinical diagnosis, but usually for IBD, you see bloody diarrhea, not abnormal CT. And then you see the entire biopsy looks normal except the rectum showing this kind of features. And this really make us thinking this could be a sexual transmitted disease. So we did an immunostain for spirochetes, and you can see it's highlight these bugs here. So the diagnosis is syphilitic proctitis that can also mimic IBD. And now we move to drug-induced injury. So first is NSAID. NSAID can induce a lot of GI symptoms and a lot of injury patterns, including non-specific acute self-limited ischemia, eosinophilic, microscopic, IBD-like, right? And also they can have a stricture with so-called diaphragm-like stricture, which clinically may mimic Crohn's disease. But if you look at the gross specimen, IBD stricture is usually a linear stricture, and NSAID-induced stricture, we call diaphragm-like. It's like a transverse web-like stricture. So that you have to keep in mind. And for NSAID injury, usually you will see a lot of pseudopyloric metaplasia, which we also see in Crohn's disease. And you can see this pseudopyloric metaplasia, which very easy to miss because they look very bland, and our eyes usually see blue things, right? If the normal colonic epithelium look very blue, this look very pale, we sort of ignore it. Yeah, but pay attention to pseudopyloric metaplasia. If NSAID-induced pseudopyloric metaplasia is the etiology, and usually you don't see much of the inflammation, and clinically the patient usually don't have hemorrhagic diarrhea. Okay. And next medication is MMF, and this is an immunosuppressant. Usually people use it for organ transplant, bone marrow transplant, or autoimmune disease. So MMF can give you IBD-like changes, and of course, GVHD-like, ischemic, self-limited, they can also have the presentations. And here you can see this one, you can almost indistinguishable with IBD, and you can see full thickness and basal lymphoplasmacytosis architectural changes. And this picture is almost identical to chronic inactive colitis. You see architectural changes and without much of the inflammation. So the key is if the patient is using the drug or not, right? And then the third drug is olmesartan, and this is a anti-hypertension drug, and they can cause varieties of inflammatory pattern of injury, and including IBD, and sometimes can look celiac disease, like this one. It can have villus architectural changes, some IELs, and they can have this collagenous colitis pattern, and of course, IBD pattern. And if you have an older patient with multi-organ involvement, and you should think about olmesartan first, then IBD. And immunotherapy-induced colitis, it just looked like IBD, right? And this is probably the first publication in 2017. And then more and more immunotherapy and checkpoint inhibitor was used for cancer treatment. So now we see more patterns like chronic active colitis pattern, chronic inactive chronic pattern, lymphocytic colitis, collagenous colitis, something non-specific or self-limited, right? So we did mention a lot of drugs, and there's more drugs I can't really mention. It's too many. So in general, drug-induced injury pattern, and you can see, sometimes you can see a hint, right? So first involving many organs, and you can see upper and lower GI involvement. And usually the age different, the age will make you start to suspect this may not be IBD, right? We know IBD have two peaks. One is in the teenagers, and then the second peak is in the mid-age, right? So in the mid-age, if the patient never had IBD, suddenly had celiac disease plus collagenous colitis plus IBD, you have to think about drug, right? So drug usually involving a lot of organs and had a mixed pattern. And usually each of the pattern is not so classic, right? So you start hinging, is that? So when you have that, you start to wonder if that's a drug induced, and then go to the history to see if the patient is taking NSAID, too many patients taking NSAID, and usually they don't even tell us, right? And if the patient is an organ transplant patient, bone marrow transplantation, cancer patient, or there's hypertension, yeah, think about it, go to the chart, and then you may find whatever to fit the histological changes, right? And the other one is ischemic colitis. Usually, we're quite familiar with acute ischemic pattern, and we won't think this look like IBD. But clinically, and we have a couple of cases, and clinician insist this acute it's IBD, but we find it's ischemia. So clinical diagnosis may include acute ischemia, but histologically, it doesn't look like IBD at all. But for chronic ischemia, and we do see this kind of architectural changes, and we should think about if the patient had any kind of hypercoagulative status and heart disease, or the patient had immune-mediated disease. And then finally, we get the radiation proctitis. And here you can see architectural changes, and then the gland gets separate to each other. Sometimes you do see a lot of inflammation, like this case. Sometimes they don't have this inflammation, but a lot of fibrosis. But if you see this kind of weird looking ectatic vessels, you should think about the radiation proctitis. Go look, see the clinical chart, and usually is a patient with prostatic adenocarcinomas that post radiation. So this is a typical picture of radiation proctitis, not IBD. So this is the last slide. So for chronic colitis, the pattern is not that difficult, right? And I think every first-year resident should be able to tell there's a chronic colitis, and if that's active or it's not active. But the underlying etiology is important because that will guide clinical management. So that we have to do our additional work to make sure the etiology get explored, right? So we need to know the history, we need to know the endoscopy findings, medications, and radiology changes or radiation, right? So, and then we can give a patient the etiology of chronic colitis. So I wish everybody remember we are taking care of a patient, not a slide. Okay, thank you. Any questions?
Thank you very much, Dr. Chin, for giving us such a comprehensive overview. I believe there are some questions in the Q&A boxes.
Let me
If you
see.
can find it.
Oh, okay, yeah, here I
Yeah.
see Q&A. So the first question, how often do you see true co-occurrence of UC and Crohn's? Huh, that's a good question. And we usually don't make that kind of diagnosis co-occurrence, right? So UC is UC, and Crohn is Crohn, and sometimes there's a mixed feature, and we call it indeterminate, or we don't know. There's and we wait for the feature getting developed, right? So we usually don't. I don't know anyone use this terminology or not. Okay, so next one is sometimes colon biopsy to rule out microscopic colitis show lots of mitosis. Okay, that's a very good question actually, but no feature of microscopic colitis. What that mean? So usually when you see mitosis, right, and that means it is the colon is regenerating, right? And if the patient don't have like a current injury, and that means the injury is probably treated or they burned out or something. They just, mitosis is basically, it just means regeneration, doesn't tell any underlying etiology. So, okay. Then next one is sterile colitis, similar to ischemic. It look the same, but the location is different, right? One is more in the rectum, the other more in the watershed area, right? And we don't have much of the unique feature, yeah. And next one is quiescent colitis inactive. Okay, so this two terminology is basically interchangeable depending on who like to use it. And for me, I rarely use quiescent colitis, and I use it only if I see I only see crypt architectural changes, but I don't see increased lamina propria lymphoplasmacytosis. Inactive, I can see a lot of lymphoplasmacytosis in the lamina propria, but don't have neutrophils. So basically, inactive is versus active. Quiescent, usually I see like nothing but architectural changes. Do you always give differentials? We try to limit the difference, because I always think when clinicians give us the biopsy, they have like a few differentials, right? And our job is try to make that list shorter. So, at least at Cornell, we try to, now I have to say there are two different kind of pathologies. One, let the clinician on driver's seat. And at Cornell, we like to be on driver's seat. So usually we will give a definitive diagnosis unless we cannot really do. That's, yeah. So if patient had UC pancreatitis, refer to treatment to penile surface. Resection shows patchy transmural inflammation, Crohn's-like aggregate. So should indeterminate. Okay, so that is a very good question. The patient refractory to treatment, probably not because the patient had Crohn's, right? Because medically nowadays, Crohn's and UC are treated the same, right? So it did not respond to treatment doesn't mean this patient is Crohn and they should treat like a Crohn's, yeah. And so if you do see some lymphoid aggregate, a little bit this and that, it's also depending on the history. If the patient had history of fulminant colitis, right, and this little bit transmural, probably what left over of the fulminant colitis, not quite completely treated yet, right? And you can also call indeterminate colitis, but indeterminate colitis, 80% of indeterminate colitis eventually will be determined, and 80% of them are UCs, right? So when we call something, right, one disease versus another, we also need to think how the patient will get treated, right? So we want to know it's a UC or it's a Crohn's, because UC patient will get a pouch, and the Crohn's patient usually do not get a pouch, But nowadays, if there is a superficial Crohn's, they still do a pouch. So, but in general, if the Crohn's patient will not get pouch and UC patient get a pouch. So if you call this colon indeterminate colitis, or you call it is UC, patient will be treated the same. They will treat indeterminate colitis as UC, right? Unless you say indeterminate colitis favor Crohn's, and then they will hold pouch. Yeah. And then how to differentiate microscopic colitis versus ischemia? I think that is not much difference, not much similar, right? The microscopic colitis, usually you see inflammation, right? You see either intraepithelial lymphocyte or you see subepithelial collagen for microscopic colitis. Ischemia, yeah, I don't know, this is for acute ischemia or it's a chronic ischemia. I think that the histologic feature is not that similar. Okay, how do you evaluate random TA versus dysplasia associated with IBD? Yeah, that is a very good question, but nobody can answer. So, and in general, we actually have like a quick text. Yeah. Basically, we say the distinction between sporadic adenoma and the dysplasia associated with IBD cannot be distinguished by histological examination alone, right? So they need the endoscopic correlation. But in general, if the patient, if the tumor is, if the tumor arising in a segment of colon which never been involved by IBD, or if the patient had older age and shorter duration of IBD, it's more like a TA. And otherwise, it's more like, yeah, so you can find a lot of code, either from Cornell or from Sinai. I'm sure from many institutes, they have this code. Basically, tell them we can't really tell. You have to do the endoscopic correlation. Yeah. And do we do grade activity? Yeah, that's also a great question. Yeah. So depending on where you practice, there is now a general criteria everybody accepted. I think when you're talking about 50%, you probably heard or trained at Mount Sinai. So when I was at Mount Sinai, I do that. And I was at Cornell, I don't do it. Yeah, the thing is, clinicians don't really care about what we say. Yeah, they had endoscopy features and they know how bad the colon is, and they know how bad the diarrhea is, how much blood the patient lose. So they treat patient based on their clinical picture, right? So we say mild, moderate, blah, blah. It's all depending on what clinician they want us graded, that's okay. If they don't want us graded, that's okay too. But there's no well-accepted criteria for grading. Yeah. And pouchitis and diverticulitis do you usually grade, and that's the same. We don't do it. Yeah. And then okay, here, small superficial granuloma could be ruptured. Yes. So this also is a good question, right? So, we talk about granuloma is could be Crohn's and could be a lot of other things, which including ruptured crypts, right? So if we're sure this is a ruptured crypt, right? You can, see there's a bad crypt and then, there's a, granulomatous inflammation. We know it's ruptured crypt. We don't mention it in our report because clinicians somehow they learn from their medical school. Once you say granuloma, they think that's equal to Crohn's disease. So no matter how do we explain this granuloma could be blah blah, they don't take it. Yeah. So in non-IBD setting, I will say yeah granuloma blah blah, but if in IBD setting, I try to avoid using granuloma if I don't think the patient had Crohn's disease. Even like a foreign body granuloma, I don't use that term. I say foreign body giant cell reaction. So because our report is basically you need to know who read it and how they interpret it. Our pathologists know, oh yeah, this and that, and granuloma means a lot of things, not just Crohn's. But clinicians don't really think that way. They read from textbook granuloma, right? They don't see before the granuloma you have blah blah, after granuloma you have blah blah. They read one word and they interpret that as Crohn. So our report tried to avoid this confusion. So in Crohn's setting, I don't use granuloma. Yeah. And okay, so next one is, yeah, so basically along the same line, true granuloma versus cryptolytic granuloma. And this term is also sounds like from Sinai. Okay, so yeah, this I said, if you see a ruptured crypt, right? And then of course you can say that's cryptolytic granuloma. And sometimes it's hard, right? And the true and also rupture cryptolytic granuloma. Sometimes you see more inflammatory cells. Other than histiocyte, you see neutrophils, eosinophils, right? And then if you see a ruptured crypt, and also you can see this crypt, this granuloma may not have it, but the next one has it, right? So that's probably the same thing. They're neighbors. They look like the same. Yeah. But again, I will say this two granuloma is not that easy, not always that easy to differentiate. Yeah. So they want to evaluate chronicity in terms of ileum when they say erosion. Okay. concern CD. If the biopsy shows pseudo pyloric metaplasia, which means chronicity, should I give comment? Yeah. So yeah, that's depend. Yeah, I think you do have your differential already. There's NSAID versus Crohn's, right? And if NSAID, of course, the patient has to take NSAID, and usually you don't see a lot of inflammation, and you don't see patient had diarrhea. And the Crohn's disease, you may, unless it's a treated, right? But treated, you have to have a history of treatment for Crohn's disease. Otherwise, you cannot really do it. But I think we take very serious to call patient Crohn's versus UC, right? So the patient may have UC, but also taking NSAID. That's all case based. Yeah, but in general, if you have inflammation, you have diarrhea, that's Crohn's. If you don't have anything that's NSAID. But also, you remember pseudopyloric metaplasia is not specific for these two diseases. If the patient had a previous resection in this area, right, and you may also have pseudopyloric metaplasia. Yeah, but don't just. Yeah, I think for IBD and calling Crohn's, we're more conservative and not to just directly give a patient IBD, Crohn's, because this clinician, once they take that, and the patient will carry the diagnosis for life. Yeah, so we have to be very careful to label the patient with IBD and label the patient with Crohn's disease. How to diagnose it in terminal ileum? I feel very difficult. Yeah. So yes, I think for terminal ileum, because terminal ileum usually have a lot of lymphoid aggregates. So these lymphoid aggregates will sort of push the gland. So the architectural changes is not a reliable feature for chronicity, right? And so for diagnosis of terminal ileums, first you see a lot of plasma cell infiltration, right? Lymphocyte doesn't really count. Plasma cell infiltration. And I really, really like to see pseudopyloric metaplasia. That's, I think, it's more definitive. Architectural distortion, unless it's very outrageous, and otherwise I want to call it a chronic. Pseudo-inflammatory polyp, and I use whatever term. Yeah, inflammatory type polyp, pseudo-inflammatory polyp, inflammatory. Yeah, I use it all of that. Yeah, I don't think it matters too much. Okay, great.
All right. That's why
Yes.
we have
Ah.
covered all the questions we have.
Answer all the questions. I hope it will help for your future.
Yeah,
Yeah.
definitely. Thank you again, Dr. Qin.
Okay. Thank you.
Very good
Mhm.
talk. And thanks to everyone for joining us tonight and contributed great questions. And we hope you all enjoyed this session and then learned a lot. And I think, yeah, see
Okay.
you in our next lecture.
Thank
Have a
you.
great night.
Mhm.
All right.
Okay. Bye-bye.
Bye.
Bye.